Hi.
Hi.
So finally get to do this session with you.
That's right. It's been a while.
Yeah, it's been a while since we've
But
been
then,
planning on doing this, but somehow something or the other just kept happening, and the last one was just
yeah, no,
crazy. I
that was
mean,
yeah. I'm really sorry to hear that though. Yeah.
yeah, I mean, a very, very young man just lost his life just like that. I mean, it was like, it shows the
Aspect
fragility of life,
of life. Very
Yeah, and
true.
it
Very true.
and it really shakes you up that what are you doing, But anyways, that's something which we'll all have to cope up with.
Hmm.
It'll take a lot of time, but like I said in my post, the show must go on, and we are back here.
Yes.
So Doc, welcome to our channel, and I'm so happy to have you over for this session.
Very happy to be here, and I really admire all the effort that you have been making in the past to create awareness, to talk about new things. I think endometriosis, the more we speak about, the more we talk about, it's only going to help, no matter what knowledge you get from where, because often enough people don't know what they're going through, and very little people who probably can guide them as to what's right and what's wrong. So
Absolutely.
anything that you do for making people aware is only going to help us in the endometriosis community to actually get the right support they require.
True, absolutely
Yeah.
true. So, just a small intro about this amazing person with me, Dr. Anshumala Shukla-Kulkarni.
Yes.
She is one of the most well known and well experienced gynecologists and laparoscopic and robotic surgeons practicing at Kokilaben, Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. So she has done her advanced training in Singapore and Australia and previously has worked with prestigious hospitals like Saifi Hospital, Mumbai and St. George Hospital, Sydney. And today we are going to be talking about something that is really important, extra pelvic endometriosis and the role of technology when it comes to endometriosis. So, Dr. Anshumala, I am eager to start this conversation because there are so many questions, so many things that are there in the mind, and this session probably would be long. So, just a disclaimer.
Yeah,
So, so let's just jump in directly to the questions.
sure.
Can you describe any unique or unusual symptom that the individual experienced before receiving a diagnosis for endometriosis?
When you start seeing a lot of endometriosis patients, we all know they're going to have pain and the obvious signs where somebody has infertility and then they come and get diagnosed, and it's very easy to jump at it. But then you have someone who comes in with the symptoms which are often enough. So, like, I've had these unusual patients who've been referred to me because of other specialties sending them to say, look, I don't know what's wrong. Maybe it is God, because I keep talking about endometriosis so much in my hospital as well. So now everybody in the
Correct.
hospital that I work in is sensitized to this disease. And it so happened that we had our oncology thoracic onco surgeon, and he had this nun who came in from the Middle East. She was working there. She belonged to Kerala, and she had come in with repeated pneumothorax. She would get this and
Oh,
difficulty in breathing, and then obviously nobody asked her anything about her periods. And she landed up with the thoracic surgeon, the thoracic oncology surgeon, saying that, there is some mass that they're seeing on the CT scan and they're not able to find out what it is. And she gets this continuing pain and, hemothorax, pneumothorax happening all the time especially on the right side of the patient. So he
okay.
said, he saw the CT and he thought, okay, let me see what it is. He does thoracoscopy. He does the same thing as you do laparoscopy for the tummy. You put a telescope in the thoracic cavity.
Correct.
You don't have to make a big cut and you can look. He looks in and he sees these bleb-like structures and, of
Mm.
course, a powder brown mark happening in the pleural space. And that's when he kind of clicked to him that, okay, maybe this is not just a mass, is probably is endometriosis. And he just goes ahead and calls me in from my outpatient and says, like, please come and have a look at this. We need you to see this because we just want you to confirm if this is something that actually it comes from what you deal with. And I go into the OT, and yes, this was very typical endometriotic lesions with blebs. So the inflammatory vesicles that you generally see, these are like blebs, water-based blebs which you see all around. These are inflammatory markers you see on the covering, on the pleural thickening covering. In the peritoneum also you see it. And then behind them you had these marks of powder bone thing. So then he finished his part of the surgery. We got the patient out, and then is when I went and spoke to her after the surgery was done and everything, and she was in a recovery, to check with her what were her symptoms. And of course, she said that this was there, but nobody had thought of correlating this with the period cycle. Nobody ever spoke to her about it, asked her whether this is actually related to anything like that. Then when I started asking her, she said, yes, she has extremely painful period. Painful period is something that she's always been, we always had it ever since she was in school, but she always thought it was fine, and she never thought until she started developing this is when she went to seek a doctor. Otherwise, she was just popping medications, going about her work in the church, and she never thought of actually having that painful period checked. And how they are not active, they're not active sexually also. So for them, these symptoms probably was not something she thought about, that the pain should be something very different that I should be dealing with or even asking help for. So we get the MRI done, we get the ultrasound done, we find out that she had large endometriomas, she had a full poucher Douglas which is obliterated, like a typical stage 4 endometriosis.
Correct.
Of course, we treated all of that as well for her, and she's well now, and she's come back, and of course now she doesn't have any of things. But this was someone who came into the thoracic oncology. And
Correct.
then, I get called in the middle of their surgery and it was only and only because I think maybe the diagnosis would have come through if after the histopathology had come, and I would have not had a chance to see. And it's only because of the sensitization that all the doctors in the hospital have, and I keep talking about endometriosis so much, that he thought of it. And he said, no, maybe, we should get her to come in and see this because this could be related to it. So this is some of the bizarre ways in which, endometriosis actually comes to you. And oddly enough, of course, nobody would ask. I mean, if you go to things like, I had a patient who had come in from Canada, and she used to have not much of dysmenorrhea, not much of painful periods, not much of a thing, but she had IBS-like symptoms. Now, we all know bowel symptoms are so typically associated with the endometriosis patients. Correct. Because of their inflammatory nature and their sensitivity to certain things in the diet. But nobody had actually pointed that out to her. That maybe she was told that maybe she has Crohn's, maybe she has, put her off gluten, put her on all of things. She lost massive amount of weight because she was put on all of these medications. And it was obviously going to take typically about 6 months to get an MRI done, because that's how the health system works. That's in that place.
Right.
So she comes back, So she comes back to us, and she came to me because she thought she should get an opinion about her periods as well. And she was seeing a gastroenterologist as well. So we said, let's get the MRI done. And of course, she had endometriosis. And all it needed for us to do was, she was already 48. She needed a hysterectomy, bilateral sulfing-oophorectomy, counseling with regards to diet and everything. And she goes back and she has no pain. She was actually referred to a psychiatrist by that time in Canada, saying that your pain has no meaning. It's not going anything. You've taken everything and you're still having pain. So, you need to go and see a psychiatrist. And she says, I can't be thankful enough for this. I mean, I just wish somebody had listened to me, or I had access to getting a better diagnosis done before, I had to go through all of these things. And then there was another patient who had come in. She's actually a medical student, and she used to faint in the wards. She used to just drop, just faint, because the pain, she would get sudden excruciating pain. But that pain would be lasting only for about 2 days after the period is kind of on the end. It was not like not a very painful period per se. And she had started developing a nodule in the inguinal region. And and then everybody started talking to her. Maybe you are working in a medical college. Maybe it's tuberculosis, maybe it's infection, and all of that. And it was a proper nodule. She had actually developed She had developed an endometriosis in the canal of Nook. So this is the canal which connects from inside the abdominal cavity to the outer area where the start of your mons pubis is. And any blood that is tracking along in that area can actually form like a mass, which was endometriosis essentially. But then her pain used to strike her just after the period, probably when the fluid had collected. There is when she used to get that extreme pain, and during her rounds in in the hospital. She started to suddenly faint. Uh,
Mm.
she was told all of this thing, but then she thought of coming into a gynecologist, and then that's when we said maybe this is endometriosis. Some patients have had FNACs done for this. So
Correct.
FNAC is like a fine needle aspiration. So this is a lady who comes to me who is 45, and she has a mass in her vagina. Okay, and painful mass, painful periods, very hard mass, which the gynecologist has seen, looks at it and thinks maybe it's malignancy, does an FNAC from the vagina to diagnose this, because they couldn't understand what is this Pouch Douglas mass which is there. Uh, the diagnosis did not show anything conclusive, whether they didn't get a proper sample or whether it was just fibrotic tissue they got in it, God knows what. She comes to me, and of course she had a huge Pouch Douglas nodule extending up to the vagina or into the rectum, and we had to go ahead and do a hysterectomy, BSO, do a rectal segmental resection for that, remove that inside that part of the vagina and suture it back again. So now this patient was being told you have cancer. This is a hard mass, and like you probably thought of it as being a cervical cancer or some bizarre thing that could have happened. Another patient again who was told she has cancer is an old lady. She's menopausal. So, generally how
Yeah.
we feel menopause is some time when obviously endometriosis lesion do respond to hormones, and they do have a synergistic response as endometrial tissue would have, similar to the endometrial tissue. But they can still grow even if you become menopausal. That is something not recognized or not talked about or not thought about also by a lot of people. Patient comes with mild spotting and
Mm.
abdominal discharge. Okay. And they do a pap smear. The pap smear shows abnormal squamous cells of uncertain, what ascus it is called. Okay. So when they see this, they say we have to do hysteroscopy to find out where this is coming from. Cervix is flush to the vagina. You can't really see much. Ultrasound doesn't show anything. They try to put the hysteroscope inside, can't see anything. There's too many adhesions inside the cervix. They just can't associate and go inside beyond that particular thing. And she got very scared. She thought maybe, I've developed some advanced malignancy, not
Yeah.
even able to take a biopsy. Maybe there's something else. So we decided to she came to me, we decided to do a hysterectomy. And of course, the endometriosis is in the cervical canal. And this endometriosis was active, and it had caused adhesions in the cervical canal. So you could not put a telescope inside the cervix. You could not see anything, but she was having symptoms. So it postmenopausal lady with all of these things. So I mean, this thing can present in so many ways, and like I said, different specialities have actually brought these patients to me to say that maybe this has got something else to do with you and not really. That's for
So,
some of the bizarre cases that I have seen.
so what, like we have been saying this earlier also, day in and
Hmm.
day out, that they are, so first of all, you need to be vocal about endometriosis.
True.
People need to talk about it, because people otherwise, even the doctors per se, don't know what exactly it is, how to
Hmm.
diagnose it.
True.
So only when you start talking about it, people are, like you said, that people in your hospital are sensitized towards
That's right.
endometriosis. So at least they have a clue. Right. And
True.
secondly, obviously, taking an entire history, a 360-degree history is something
Very
which
true.
may really help.
Very true.
So what were, you just told me about the atypical locations.
Hmm.
So did the individual exhibit any other thing, like besides pneumothorax or bowel problem, IBS? Are
Hmm.
there anything else which are associated?
Hmm. So patients have had sciatic pain. They have been
Mhm.
to spine doctors, and they've had sciatic pain radiating all the way down to the leg. And this patient had gluteal pain actually, not so much of
Mhm.
sciatic pain. And again, here the symptom was not anything to do with periods and pain, but she just had this isolated pain in the sciatic nerve on the right side. And this endometriosis generally goes to the right in the sciatic nerve. And so what happened is that she had ultrasounds done. She'd not had MRIs done, and she came because some other doctor had done a hysterectomy for her, left the ovaries back,
Mhm.
and then she kept having this pain. And at that time, the reports showed mild adenomyosis and nothing more than that. She had her ovaries in place, but she had this pain, the sciatic pain, and typically going down the leg, inability to walk. So when she came to us, we did an MRI for her, and MRI is the only way to diagnose sciatic nerve endometriosis. And because she had these symptoms, we made it a point to make sure that we do an MRI which focuses on the pelvic nerves. And she had about a 1.5 centimeter lesion sitting on the sacral nerve roots. So we went ahead
Okay.
and did and excised it. Of course, he did a oophorectomy for her as well. She was 46 years of age, but she did well post that. So again, this is, you know, a symptom which didn't have anything to do per se with endometriosis and typical symptoms, but just kind of you know, showed up as having an irregular, uh, I mean, an irrational pain, like a sciatic pain, which is coming up. So,
That's right.
yeah.
That's right. So, what were the challenges that this particular, I mean, any particular person who has extra pelvic endometriosis generally faces when it comes to, you know, diagnosis of endometriosis?
You know, patients who have endometriosis have challenges even if they have pelvic endometriosis to get diagnosed. So it's really hard. I think most of the extra pelvic endometriosis, they have to be diagnosed. It would probably happen at the time of surgery if the surgeon is good enough to look at the appendix, look at the liver, look at the diaphragm, and make sure that they are looking in other areas as well. Otherwise, it's merely going to be a question of trial and error. They are going to find, because they are not going to come to the gynecologist first. They are
Correct.
always going to go